There we are. Fantastic. Good morning, everyone. Thank you so much for taking the time to join us today on this really interesting topic. And there's been a lot of interest in it, so we're really glad to have such a varied audience with us today. There'll still be people popping up just for the next couple of minutes, I think. So welcome everybody in, and we'll make a start. I'm just going to begin by giving an overview of the Child Health and Wellbeing Network for those of you that aren't familiar with it before we hand over to our chair, Professor Judith Rankin, for the rest of the session. Hello, my name is Jenny Hicken. I'm one of the network delivery managers in the Child Health and Wellbeing Network. So we run these huddle webinars on a semi-regular basis on lots of different topics, and they're a really interesting way to really get into a topic because there's plenty of time for discussion and Q&A, and you can hear some of the fantastic work that has been going on within the region on this topic of social prescribing and perinatal mental health. You are in the right place. So next slide, please, Amelia. I'm just going to go over a little bit about the network for you. So what is the network? If you move on, just keep us rolling. So the Child Health and Wellbeing Network has a function to bring people together, essentially. We build relationships and build networks. And we sit within the whole region, North East and North Cumbria, across that big footprint. I'll show you a map if you're interested what area we covered. But essentially, it's our role to bring people together, to work together, to make things better for the children, young people and families in our region. And a lot of what we do is this sort of thing, sharing good practice. And we also drive forward some work programmes that we're involved in, and just connect people together to make things happen. Next slide, Amelia. Thank you. So we do sit within NHS England. Currently we are hosted by NHS England, but we've always sat within the integrated care system since that started to develop in 2018. We're imminently moving into the Integrated Care Board as our host organisation from April, so that will hopefully make us really embedded into the system locally. And you can see there on that map, there's another map coming up which you can probably see a bit more easily, but that shows our footprint. We're all the way from Scottish borders down to the tip of North Yorkshire and all the way over to West Cumbria, but it is just that top half of Cumbria that we cover, so it splits the county in two, and a lot of that geography is due to patient flows and that sort of thing, and the way that it works coming across to the east from the west rather than going south. So a lot of our reason for being essentially is around the deprivation that we see in our region, and the levels of poverty that we have. We work quite closely with third sector partners in this area, so the North East Child Poverty Commission we've linked into quite recently around their child poverty strategy development. We know it's a huge issue for us and the families that live in our region, so that undercuts a lot of the work that we do. Thanks, Amelia. So when we're talking about deprivation, we're talking about that lifelong impact. And when we're talking about perinatal mental health and maternity in early years, that's where those impacts of poor health outcomes can really impact through that lifelong life course. And we're talking about things like living in cold homes, living in damp conditions, that if you've got a baby in those conditions, you're sort of baking in those difficulties for their future. So we really have to focus on that life course approach and what we can do from the very earliest stages to give babies and children and then young adults into the future the best chance in life. Thank you, Amelia. So some of the setup of the network, just to sort of give you a broad background to it, we had a lot of engagement events around what our priorities should be. And we had some residential meetings and these events here, which seem a lifetime ago now, all pre-COVID, when we identified the priorities that the network would work on. And we had some fab young people's engagement at that time as well. And if you just move on to the next slide, Amelia, this whole process helped to identify the network priorities. So this is our priorities wheel, if you've never seen this before. It has children, young people and families in the centre, and these are the priority areas that we were mandated to deliver on by the system that we work within, underpinned by those enablers and cross-cutting themes as well. And you can see that mental health is one of the top ones that comes out every time. And when you're talking about mental health of babies as well, closely links into perinatal mental health. So obviously a huge priority for us. Family support, strong start in life, it's all there, and it all interconnects, and none of these really exist in isolation anyway. So that's how our work program is based around. Next slide, Amelia, thank you. So just this slide should help you show the geography a little bit more clearly. So when we're talking about children and young people in the network, we're talking about 0 to 25. So the 0 to 17 population on this stat is about 20%, and you're looking at about 25% of the population if you're talking about 0 to 25. So it's a significant number of people when you're talking about children and young people. So it's a really important area for us to get right. Next slide, Amelia, thank you. Just to give an overview of our membership, probably need to update this now as well, but we have almost 2,000 members across the system in the North East and North Cumbria, many of whom work within health, given that we are health based, but we always talk about ourselves as being a cross system network, and we work into all sectors that have a hand in child health and wellbeing in some way. Education is huge for us. We work really closely with local authority and public health partners. VCSE organisations are really important to us, and we do so much work into the voluntary sector because that's where a lot of this work in the community at place is really happening, and there's some great stuff being delivered by VCSE organisations. And then we have a split across the geography as well, depending on where people are based. But anyone and everyone is welcome to join the network. If you have an interest in child health, we would encourage you to sign up today so that you can make sure that you receive all our communications about anything that you might like to be involved in as well. If you move on, Amelia, thanks. And again, that's just a little word cloud just to show how much we do, because there is a lot. I would be here all morning if I tried to explain everything to you. This is just to highlight a resource that some of you might find helpful. If you're interested in some of those priority areas, this is a data resource that was pulled together in 2021, although to be fair, it will still largely stand today because if anything, some of the metrics will have probably gotten worse in the last couple of years due to the effects of the pandemic. So this is just to highlight some of the sort of key demographic data, key metrics in those certain areas that might be of interest to you, and they can inform some of your work, especially if you're interested in health inequalities, especially. That's a really useful resource for you. Next slide. Just another highlight of some collaborative work that we've done. If you're interested in research, we have partnerships with the universities for evaluating certain pieces of work. We've done pieces of work around research and education settings so that we can work with young people directly. And the tripped resources that are highlighted there, if you've got an interest in that fuel poverty agenda and families having warm and dry and safe living conditions, there's a really useful resource for you there as well around supporting families who may need signposting to help in that area as well. All of this we can share with you afterwards, don't worry. And just move on a couple of slides, Amelia, you can probably skip the next one. Yeah, and this is just to sort of highlight everything that we've done there, and there is a QR code for you there. So if you want to join the network using your phone, we will send you a link that you can do it over your laptop as well. But if you want to use your phone, you can sign up to join the network there and get onto our distribution list to receive all of our comms. Last one, thank you. And just finally, Al Ainsley Green was the first Children's Commissioner for England back in the day, and he was really supportive of the development of the network when we were having these launch events back in 2018, and gave us some great advice. And he sort of gave us this quote to use, that if we don't advocate for the needs of these children and young people, then who else will? And quite often it feels like we may be the only ones speaking up for them. So it's a really important job for us to do. And appreciate all of you giving your time today to help make things better for everybody. And I will move that on to our amazing chair for today, who we're really grateful that she's given her time to join us, Professor Judith Rankin, Professor of Maternal and Child Health at Newcastle University, and she also sits on our network board as an executive member for research. Thank you so much, Judith, for being here. I will hand over to you for the interesting bit of the session. Hope you all enjoy it. Thank you.
Thanks very much, Jen, and thank you for that very generous introduction. So it's an absolute pleasure to be here today to chair this meeting. I know this huddle is going to be very interesting for all of you, and I just want to reiterate the thanks for all of you giving up your time to join us today. I think the number of registrations that we had reflects how important this area is, and I don't intend to spend a lot of time convincing you that it's important, because I think that job is already done. But just to remind us that 1 in 5 women experience mental health during pregnancy or in the postnatal and first year of life, and those figures are likely to be an underestimate. I think this area has got huge policy relevance. The NHS long-term plan renewed the commitment for the NHS to improve specialist perinatal mental health services. The Ockenden report made a number of recommendations around mental health, and obviously the NHS mental health implementation plan is relevant to perinatal mental health as well. So the purpose of this huddle is really an opportunity to bring people together from a range of different sectors and different professional groups to really explore perinatal mental health together, and to try and understand how we can work together and in partnership to make a difference for these women. The way we're going to organise, or the way we've organised today, is that you're going to hear about 2 recently completed, one recently completed and one ongoing project. One looks at access to services, because whilst there are services available, they're not being accessed by all population groups and community groups. So we need to understand what the barriers are to that access. And then you will hear about a project that's involved prototype models being run through the VCSE sector, very much with a test and learn focus. And we'll hear about the impact that those prototypes have had. So we will then move in, and I will ask, unless there's a burning question at the end of each of them, I will ask everyone to hold their questions, but keep them held, and do use the chats. I think it's important to say we are welcoming questions in the chats. We'd also love you to ask and come off camera or come off mute and to ask them. So we will capture, but I will just remind you that we will be saving the chats. And obviously we'll be very interested in the questions that are coming through, and especially if we don't have time to answer them all. But we have put 45 minutes aside because we have a panel, and the panel will introduce themselves after the comfort break. We've got a 5-minute comfort break at 5 to 11. And then it's very much open to questions and comments to the panel. Our speakers will be on the panel as well, and we have invited others to be part of that panel. So I think in the interest of time, and I do like to keep to time when I chair things, so we will move on, and I will invite Dr. Lem Gongala to start her presentation with an introduction about herself, and then a presentation about this project around accessing maternal mental health services. Lem, I'll hand over to you. I think. Has Lem arrived?
I'm just checking, Judith, and I can't see that Lem has arrived. I've just sent her an email now, making sure that she has our Teams link, but I can't currently see her on our list.
Okay, so I wonder then if we could change the order of the presentations, Ange, if that's okay with you.
Let's do that, yes.
And then we hope that if I'll quickly contact her as well, make sure she's not having any problems getting onto the link. Okay, so we'll move to Ange, who will give the first of the talks about the VCSE, maternal mental health prototypes. Thank you very much, Ange.
Oh, thanks, Judith. You'll see that I was supposed to be joined by Rachel MacDonald. Rachel's unable to join us today, but she sends very much her best wishes. And really, I want to thank Rachel for all of her support through our steering group of this project. So I'm Ange, I'm VCSE Maternal Mental Health Project Manager at Ways to Wellness. We're an innovation hub working across the North East and North Cumbria. It's a pleasure to speak with you today, and was really, really thankful to the network for inviting us to work up a huddle idea together, and to you, Judith, as our chair, to all of the panel and speakers today for your support. Thank you for being here. For me, this is a topic of personal significance. So I came to this project as a man with my own experience of postnatal depression, and I'd spent a number of years, once I'd recovered, involved in providing peer support in the community. I share that because it's really important for me that this project was rooted in lived experience, and the services that we've developed together are very much co-produced with women with lived and living experience of maternal mental health. So today I'm going to talk for about 20 minutes about the 4 VCSE based maternal mental health prototypes. I'll share some background about how the funding came in for that work, how we've used that funding to support now over 300 mums, how we've learned together as a test and learn model really, and what we've learned, and say a bit as well about some of the unforeseen and some really exciting benefits that have tipped out of this work too. And I'll share some thoughts about next steps. But I think really I'd like for us to think about how we might generate some next steps together today. Next slide, please. Oh, thank you. So to set us up for the next 20 minutes or so, what I'm going to be presenting today is it's a low cost, it's a high value preventative support. It appears to be reducing demand in the health and care system, complementing clinical approaches. We've been doing work that is really addressing health inequalities with benefits not just for the mums supported, but also for their babies and for the wider family unit too. We'll hear a bit about why we think it's really important that this model was based in the VCSE, both taking on board feedback from the women that we've supported. We'll also have a look at how the prototypes have generated both additional funding and some resources, as well as better joined some things up for the benefit of mums and babies. And we'll also hear about how professionals have reflected on the collaborative work that we've done together too. Next slide, please. So by way of background, funding for this work came on stream in 2022 from the ICB and Perinatal Mental Health Clinical Network through the NHS England Fast Follower programme. So as clinical pilots were getting off the ground around maternal mental health in North Cumbria and in Sunderland and South Tyneside, we were looking at how we might offer support to mums with mild to moderate mental health needs within the VCSE. Ways to Wellness acted as a special purpose vehicle to disperse this funding to 4 VCSE organisations listed here, and to bring the 4 together as a learning community. And we've used that funding to fund 4 specialist link worker prototypes, with 1 worker in Sunderland, 2 part-time in Northumberland with Every Turn Mental Health, 1 in Teesside with Teesside Mind, and 1 in North Cumbria with an organisation called Together We. And we've also funded some peer support offers that sit alongside the one-to-one link work. Next slide, please. Very briefly, these are the design principles that we held in mind when we were developing the prototypes. The link workers have very much been working to integrate in their local health contexts. You know, the roles in each area were quite carefully crafted with this test and learn approach to be place-based, to be meeting local need, and fundamentally really to learn about what works. So Salma, our link worker in Middlesbrough, works with minoritised ethnic communities, and she has heard and learned about different needs to Veronica, our link worker who's based in Well Up North Primary Care Network in rural North Northumberland. Next slide, please. Thank you. So just to say a bit about the role of the link worker, social prescribing link workers spend time getting to know the person. We say that it's very much a what matters most to them type of service. So it's about connecting people, in this case, mums with mild to moderate mental health needs, to community-based support. We work together to co-create a plan to explore activities and services that meet the practical and social and emotional needs. And that will include connecting women to more statutory services, for example, housing or finances or welfare advice, but also to community assets. And it feels really important to say that it's about so much more than just signposting. So we might identify if a mum's experiencing social isolation, she might like some support to attend a mother and baby group. We wouldn't just signpost to the mother and baby group if she wanted support. We would be able to have the link worker go with the mum for the first time to explore the group, might go for a couple of times together as the mum builds confidence to be able to move forward and to attend the group on her own. So it's very much about connecting to those local community assets. And I think it works particularly well for people with low-level mental health needs who perhaps feel that loneliness and isolation, as we know that can particularly come up during that perinatal period. Next slide, please. Let's have a little bit more of a look at the model in detail. So the model for MAMS is a non-clinical link work support. We support women with mild to moderate mental health needs from pregnancy up to baby's second birthday, so that time period that we call the first 1,001 days. Referrals come in through a range of referral sources, so from midwifery, from health visiting, from general practice, from perinatal and community mental health. Some of our organisations also accept self-referrals from women. I think one of the things that we're asked quite often is how does a service like this fit alongside a universal health visiting offer, around an early help offer, and alongside the new family hub offer? How do we ensure that this isn't duplicating? I think what we've heard really strongly through our evaluation is that being based in the VCSE allows for more discretion in the role and how it works on the ground, so more face-to-face time with women. The link work role is not constrained by clinical thresholds for support. Our clinical colleagues do a really amazing job, but we also know that they're overstretched. We could also talk about some of the challenges around, waiting lists for services. This is very much a support service that can help women to wait well for support, so to stop things from exacerbating, and also to prepare women for therapeutic support. So sometimes once those practical challenges are in hand, we might be working with a woman who maybe needs some of that clinical support around her mental health, but if she's also has a lot of challenges around personal finances, for example, being able to engage with that clinical support would be really challenging. And we've heard from professionals that the support that the link workers have put in place help women to feel better prepared for those clinical interventions. And I guess one thing that we found too is that sometimes once those practical challenges are in hand, mums sometimes find that they don't need a clinical intervention. Some of those challenges have been dealt with and they feel happy and positive to move forward on their parenting journey without that need for clinical support. So we can say on average that we work with women for about 14 to 20 weeks, but I think it's fair to say that we're very flexible about that. We know that support that's needed is sometimes much longer term. More complex cases can need that additional time. We'll talk a little bit about what that complexity looks like. But I think it's really important to say that quite often these mums are not engaged with universal offers. And I'm often asked about the training that the team have had. So in addition to the NHS England social prescribing link worker training, we identified these are specialist roles. We needed specialist training in working with women during the perinatal period. We've worked with Tavistock and Portman. We opted for Tavistock because I think there was a really strong focus in that training on risk and governance that felt really important. And then we've bolted on training for the link workers around things like benefits, around birth trauma, and around postpartum psychosis. Next slide, please. So this is a learning project. We bring the link workers together once a month for a learning community session. The link workers bring cases, we share learning. There's an opportunity to look at gaps and opportunities and support for mums and really work together to agree what key learning we want to share back with health colleagues to close that feedback loop. So to give an example, quite recently we provided some case studies to support digital midwifery work around digital exclusion. We both shared what mums are saying about digital exclusion and the challenges that they face, and the barriers, but also the solutions that the link workers have connected mums to, including small grants and community IT refurbishment support. And this link work learning community approach has led us to develop this mosaic of maternal mental health factors that we see here. And the question marks that we have here are to show that this is really iterative. You know, we're still learning about maternal mental health factors. But I think it's quite a neat example to show how VCSE based projects like ours are doing more than just providing a new service. We're looking in detail at what works for who and why. Next slide, please. I'm just going to ask you to click a few times because I know on this slide things appear on the screen. Thank you very much. So what have we learned? We've learned that we're reaching the right women and we're reaching the right families. So 85% of women supported have had 3 or more support needs at referral, and 43% have had 5 or more support needs. I guess we might term these support needs in some of that local maternity and neonatal system language around complex social factors. So this will include women experiencing current or historic domestic abuse, the kind of ongoing daily challenges around poverty and cost of living crisis, women coming into contact with drug and alcohol services or supporting partners who are using drugs and alcohol, perhaps supporting older siblings with disabilities. We've worked with women who are care leavers. We've worked with women who are at risk of homelessness. And I guess all this to say that increasingly, now that the service has been up and running for 18 months, you know, we're increasingly getting referrals to support women in early help and who are at risk of child removal. And I think that this is testament to the trust that the services have built with statutory partners and with the women. I think we instinctively feel like we're trusted to work with this complexity. And the prototypes have supported 345 women, or more than 345 women, because we've got some new monitoring that I need to look at over the next few weeks, but roughly supporting 3% of their local births. Next slide, please. So we use the evidence-based parent and baby outcome star to assess women's needs and wishes. We use this as a support planning tool. And looking at our results, the primary outcomes that we're achieving are around improved mental health and well-being and a greater connection to community and social supports. We also see these secondary outcomes around building supportive routines as a new family, reduced loneliness and isolation, women feeling that they have improved social contacts, improved bonding with infant, you know, a host of secondary outcomes. I think it feels really important to highlight that we have a number of women who are making progress in employment and education, which feels really encouraging. And some of the quotes that I'll share a bit later on really speak to that. Next slide, please. So the 2 areas that are highlighted by women as feeling that things are not okay at referral are generally around their mental and emotional health and generally around their support network. So feeling really lonely and isolated during that perinatal period. 96% of women have made progress in at least one outcome area, 87% across at least 2 areas, and 54% across at least 3 areas. And the other thing that I wanted to highlight, one of the other tools that we use on the programme is the ONS4 wellbeing measures. On average, those ONS4 scores show an improvement across all 4 areas, but I think what we feel is really significant, both in the feedback from women and also within that more quantitative evidence, is a fall in women's anxiety scores from an average of 8 to a score of 5 on ONS4, and women reporting a real sense of reduction in anxiety. So, you know, how things kind of look and feel different in that cycle of change is really reflected in this quote here from one of the services around a mum with, you know, regular intrusive thoughts about the health of her baby, reporting feeling more able to balance unhelpful and intrusive thoughts, and then seeing a reduction in attendance at GP surgery and a reduction in online symptom research. So we're seeing the real impact that the service is having on women's use of services there too. Next slide, please. Just to say a bit about the benefits of VCSE-based support and what we've found works, I think it feels really important to say that that assertive outreach approach seems to be working. You know, we set out on this journey to target populations at risk of health inequality, and that seems to bear out in our data. I think it's felt really important that we've had that flexibility and responsiveness within the roles, that we have been able to offer support to women during quite often lengthy wait times for access to talking therapies or access to birth reflection services. The service really supports women to wait well during that time to hopefully stop some of those challenges from exacerbating, and also to prepare women well so that when they are able to take up that support, if that's something that they still feel that they need, they're ready to do that. And some of those really practical challenges have been hopefully dealt with during that time. I think it feels really important to highlight both building trust with women experiencing complex social factors. I know one of the things that Lem will no doubt say when she shares her slides is this real sense of mistrust of services. There is a real sense of stigma still, I think, attached to experiencing mental health challenges during that maternal mental health period and beyond. And I think women do have a real acute fear of statutory interventions. One of the things that we found is that the trusted relationships that the link workers have built up, we are now seeing an increase in women taking up early help, women who previously have refused help from early help services. We've had a number of case studies where women have now felt able to take up that support. They report better conversations with social care. And we're also starting to see some really early findings around uptake of family hub support in the signposting and referral data too. I think it's fair to say that women who are worried about coming to the attention of children's services have told us that they feel better able to speak up about their needs. And I think that probably is reflective of, you know, the independence of the service being based within the voluntary sector. We also hear from clinicians, and I guess, you know, just as equally as important as what matters to mums, we felt it was important to give that time to think about what matters to health professionals. You know, what are their challenges? How can a non-clinical support like this support them in their role? I think we've heard that clinicians benefit from greater exposure to community assets. You know, there are things that the link workers have been able to put in place for women, you know, whether that's, you know, access to small grants to be able to provide white goods or to meet some of their kind of financial challenges, to being more aware of new peer support services that are available in the community. I think clinicians have benefited from greater exposure to those things. Women have told us that they're more empowered to share more with clinicians and better able to engage because their practical and emotional needs are being met. And then this can also free up clinician time on non-clinical tasks too. And then I think the last thing, just to say a little word around some of the new peer support groups that we've been able to get off the ground quickly. Some of those groups have been able to leverage additional resources. So in Northumberland, we have a relatively new project, a peer support group off the ground in rural Northumberland, supported by Pandas Foundation, a national organisation who work to develop new peer supports for women. And also Jo, our link worker in North Cumbria, who I think is on this call, in her, alongside her kind of link work role, she also runs a sling library in North Cumbria, and she's developed some new parenting peer support and antenatal groups too. So I think there are some really important benefits from you know, having that flexibility within the funding that we had from the ICB to be able to be really responsive and to develop some new services there too. Next slide, please. Just to briefly share some feedback from professionals, I think this very much speaks to that sense of being complementary and not duplicating things. So we have a quote here from a midwife in maternal mental health services. We might set up a joint treatment plan. If we were looking at CBT and graded exposure, the link worker could act on it in the community to support them. For example, if we set the goal of going to baby groups, she could scaffold them to do that. Not much of their lives are in that hospital appointment. So being able to have that holistic picture and that community support's invaluable. Then a quote from Head of Midwifery, this is the gaping chasm gap. Women who need that extra bit of support, who've had issues pre-pregnancy that are often exacerbated, and the midwives don't have the capacity to be able to deliver that one-to-one or group working that's required. And then finally, a quote from Community Mental Health Team, because the link worker has sorted so many of the practical and financial concerns, I can really help the patient to focus on treatment now. And then the next slide, please. We have some quotes and feedback from mums. And I won't read all of these, but I think just to highlight the two in the middle there. You don't think how much having no hot water or being late dropping your child off at school can really get on top of you. It was all mounting up. I think if I hadn't addressed these things, everything would have gotten bigger and it would get harder. Helping me to nip things in the bud has made such an enormous difference. Mental health isn't always about being rock bottom. It's about stopping it from getting to that. And then the next one, when I felt no hope, she's always been on the end of the phone. She listens, she understands, she doesn't judge. She got us a food parcel, put me in touch with a charity who provided baby milk, nappies and baby clothes. I could free up money to put the little one into childcare, to give me time to help myself. I'm looking now at going to college this year. She got me the details and asked if I'd like her to go along to the open evening with me. I don't think I could have done it without support. I don't think I'd be able to go back to college. She made us feel more confident knowing I can do that. Next slide, please. So I think we've had some really great feedback there, both from mums and also from professionals who have referred into and worked alongside the services. I think it feels really important to say a little bit about what has made this work. And I think one of the really key things we've reflected on as a steering group has been, you know, the personal time often in development that midwives and health visitors connected to the projects have given to support these services to integrate and to get off the ground, and to, you know, that might be really practical things like trying to help us to get a room for new peer support groups to happen, but also really, you know, supporting women to be able to get to the right services and to have that support during that time where there maybe are waiting lists for services. I think there's also been that willingness in the VCSE to try something new. We've used a real kind of human learning systems approach with this project, to listening really deeply to women's experiences and also to working in a really relational way. And I think it's really clear that there are those of us in the system who are working on this challenge of, you know, creating new models and thinking differently about the workforce of the future, thinking about how we maybe move resources upstream. And I think this is an example too of, you know, research and practice coming together to ensure a variety of views and experiences shape provision. So as well as the MAMS study, which we'll hear about hopefully a little bit today, there have also been a range of ARC and IHR studies in development and working through to completion. As well as our learning community, we've also worked alongside Happy Mums and Maternity Voices Partnerships and partners to co-produce workshops as part of a UK Research Council funded project led out of Open Lab. So there've been a number of projects that have come together to really kind of bring that research and practice approach and really highlight the benefits, I suppose, as we started to understand the barriers that mums experienced, and really be able to highlight you know, the benefits and some of the different models and ways of working. Next slide, please. My last slide, yes. So completion of our final evaluation is very much what we're doing at the moment. We're due to report our final evaluation at the end of March. Something I get asked nearly every day is, what about dads? And the funding for this work came in around maternal mental health, but we felt acutely aware that we were both hearing things from women around some of the struggles and challenges that their partners were having during the perinatal period. So we've devoted a period of time over the last few months to do some development work with an organisation called Including Men, which is also due to be reported at the end of March, really trying to understand the support needs of fathers and partners and reach out to organisations who've been doing peer support for men and for dads to understand what works and what dads say is important to them. And then really want to end by turning to explore potential for scale and spread. You know, clearly these services evaluate really well. I think they're meeting a genuine need both for mums, but I think we've also heard, a need for within the system as well. And Ways to Wellness's role here is very much to test this model out. So as we were coming to the end of our evaluation, we found ourselves in an interesting position with an ICB restructure, which has really impacted conversations about the future of these services. And we still have some uncertainty about where funding for this work might sit. I think there's a really clear preventative aspect to this work. And there's also a clear place for these are non-clinical roles in reimagining our workforce, particularly at a time when we know there are resource challenges facing our clinicians and facing statutory services. So Ways to Wellness, I guess, having tested the model out, we didn't want to risk closing these services. The funding was due to come to an end in March this year, only to have to try to stand them back up again. So we've put in place some bridging funding for the work to continue until September 2024. But I think it feels important to say it's not our role to fund services long term. We do think there's a role for a special purpose vehicle or infrastructure support in thinking about how we might spread or scale this model across the region. And I guess the question that we're then left with is, how do we mainstream those approaches? Because there is a risk that we will have to close these down. Clearly, we don't want to do this. I think we've demonstrated both significant need and demand responsiveness. Don't think we found the service to feel like an added extra or a nice to have. I think it's felt like a really crucial way to ensure that we reach women who need support. So I think a really key question for me is how can we think differently about community-based support for women? Some of you on this huddle might be in a position to help us to explore this. You might be thinking, you know, this is currently running in 4 areas of the North East and you'd like to explore this in your area. We have put together a summary, a 1-page plan of the model, including some costings. So I guess in that sense, I'd really like to end my talk by inviting conversation. We have a Q&A today, really keen to hear your questions. I could hear as I was speaking there, lots of things popping in the chat. So I look forward to having a look at what's come in there, but very much want to invite conversation. So I think my last slide is just sharing some contact details, both for myself and also for Rachel MacDonald. I'm really happy to take forward a conversation on that basis. Thank you.
Thank you very much, Ange. As ever, excellent presentation of what is a hugely valuable project and really is showing its worth in terms of the VCSE organisations filling the gap while women wait for services. I know there's lots of questions and I'm sure you've all got lots of questions and comments you want to make. So if I could just ask you to hold those until we get to the Q&A session. We'll pick them up in the chat as well, but it'd be great if I'd really like to invite you to come off mute and really participate in the discussion when we get to that stage. And also Ange has challenged us with some questions, so maybe those of you who work in the system can be thinking about, especially that one about how we would mainstream these approaches. But I'm very delighted, and I have to say somewhat relieved, because you would have had a presentation from me then, that Lem has joined us, I believe. I know Lem was having some technical problems earlier, but I understand is now online. Is that the case, Lem? Yes, lovely to see you, Lem. So we'll just move on with the second presentation, then we'll have a short break, and then we'll go into the Q&A session. So I'll hand over to you, Lem. Thank you.
Thank you, Judith. Hello, everyone, and my apologies, as Judith already said, but thankfully everything's okay now. So I'll just be presenting findings from the MAM study, which was designing accessible maternal mental health services in the North East and North Cumbria. So I can't control the slide, so maybe Judith, you can help me go on to the next slide.
If you just say next slide, Amelia and Jen are doing wonders in the background, sorting all of this out. Yeah.
Oh, that's good. Thank you. Yeah, so just a bit about background. As we all know, perinatal mental health is a big issue for lots of women, and I won't go into much detail on this, but one of the pressing problems is that some groups of women are underrepresented in accessing services, and improving access to services is a big priority for the healthcare system. And for us to be able to do that, we need to understand who's not accessing services, what reasons, what are the barriers to them accessing the services, and what can be done to improve their access to these services. And that's what the MAM study was all about. Next slide, please. So as I said, we aimed to inform the design of accessible maternal mental health services for women experiencing disadvantage in the North East and of Cumbria. And this was a 2-phase study. In the first phase, we conducted interviews with professionals working from different backgrounds, including healthcare, voluntary, charity, and social enterprise backgrounds. And the first part of it was to understand what groups of women are generally underrepresented from accessing healthcare services. And also, we then wanted to speak to women to understand women who've experienced mental health distress during the perinatal period, to understand their experiences in trying to access the services, what the barriers were for them, and what could be done to improve their access. We excluded women with pre-existing mental health conditions, just because the conditions for them are a bit different from women experiencing perinatal mental health conditions. Next slide, please. So I mentioned the first two phases as well already. So we integrated the findings using a framework called LIVISC framework, and I'll talk about it very briefly. And also validation was just discussing these findings with other professionals working with women and working on perinatal mental health. Next, please. And that's just a description of the framework. The main thing about this framework is it looks at factors on two sides. So factors to do with the provision of services, and also factors to do with those accessing services, and looking at how these factors influence women's ability to understand their need for perinatal mental health support, factors that enable or prevent them from being able to seek care, and factors that enable or prevent them from being able to reach services, to pay for services, and also to engage with providers providing these services. Next slide, please. So we talked to professionals from different groups. These included healthcare professionals, charity workers, community workers, social workers. Altogether, there were 23 professionals that we interviewed. And next, please, there were 20 women from different groups representing various dimensions of disadvantage, as you can see on the screen. And also in the last box there, we there were women who were in different categories or these different groups. So this reflects in different intersecting barriers that these women were experiencing. Next slide, please. So in these next few slides, I'll be presenting the main themes that emerged from these studies. One of the main barriers that came up was the lack of conversations around mental health during pregnancy, which was seen to be a big missed opportunity. So a lot of the women talked about not having conversations about mental health when discussing with their midwives. The conversations tended to focus on the mom, on the baby rather than the mom and the baby. Women were hoping or expecting to have these discussions initiated, but they weren't. And also for women who had previous pregnancies, they felt there was an assumption that they probably should be better placed to handle issues relating to perinatal mental health without needing help. Next, please. I think there's a quote there from one of the participants, and which was reflective of many women's experiences, talking about mental health being barely mentioned, and there were no real conversations around this, and also nothing about who they can talk to or how they can get support for perinatal mental health issues. So the professionals also acknowledged that there's a need for this, and there's so much more that can be done during routine antenatal appointments with women, and they were hoping that this can be improved. Next slide, please. Advertising of perinatal mental health services was another issue. So there's a general acknowledgement, especially amongst professionals, that a lot of work has gone into developing perinatal mental health services, and these services do exist. But the challenge is that the women who actually need these services a lot of the time do not have information on how to access these services. And this isn't a challenge just for women, it's a challenge for healthcare professionals as well. Because in speaking to midwives, for example, we had them telling us that they do not feel that they have enough information to be able to support these women, so they feel limited in the information that they have. So there's a huge need to advertise these services more, and also provide more information and more training to healthcare professionals to enable them to signpost women to resources and services that are available, to then enable these women to be able to benefit from all these services that have been developed. Next slide, please. So we looked at interpretations of mental health, and what we understood from this study is that different people might be talking about mental health but viewing it from a different lens or a different perspective, and there's various things that can affect people's understandings of mental health, usually from a medical standpoint, which is where the definition or criteria for perinatal mental health are often set. This it's different from other angles of mental health, like from a cultural lens. So in some communities, for example, when people talk about mental health, or when people hear about mental health, they interpret that in the context of spiritual things or brain defects. So if there are services being provided to support women with mental health or perinatal mental health issues, and these definitions are not broken down to for them to understand what this is all about, then these women might tend to avoid these services because they do not want to be associated with these issues as understood within their communities. There's also an understanding in different communities of who should be involved in supporting people or women with mental health issues. So these different terminologies can influence women's ability or even their willingness to want to code services or admit that they might be struggling with any mental health issues. So there's a huge need to fully capture the different dimensions of perinatal mental health and the different issues that might be influencing this in different communities. Next slide, please. Stigma, which has been mentioned already, a lot of fear and guilt with women struggling, especially with the pressure of being seen as a good mother. A lot of women who were struggling with their mental health felt that if they acknowledged that they were struggling, then it might be interpreted as them not being fit for motherhood or them not being good moms. And so they prefer to suffer in silence and try to deal with the issues on their own. And also a lot of women decide to or prefer to not talk about it or suffer in silence because they do not trust that the services would keep this information confidential, and they're worried about their children being taken away from them. And a part of this, which came up in the discussions as well, was due to messages that are circulated in the media, in movies, where women see things like social services coming to take kids away because the mom might be struggling mentally. And so this information discourages women from admitting or trying to find support for mental health challenges. Another issue was competing priorities. So a lot of women especially women from disadvantaged backgrounds, they have to work multiple jobs, they have to work long hours to make ends meet, and you add childcare to that. So there's so many competing priorities, so many other things that are priority for them, and doesn't leave enough time for self-care. And so taking time to seek help for their mental health is seen as luxury, which they can't afford. And also the challenge of services usually not being flexible enough to accommodate the needs of these women. And that's flexibility in terms of timing or geographical location, or even in terms of how services are being provided. For example, some services needing women to come in person, or the possibility for women to attend services virtually. So there's a huge need for this flexibility, which I'm going to talk about later on. And also the issue of stigma was very prevalent amongst especially women who had struggled to have kids before. So if a mom had maybe had a miscarriage before, or struggled to have a baby before, and then she had one and she struggled, she wouldn't want anything to take that opportunity away from her. And so just this idea that admitting or acknowledging that they might be struggling might then mean that they're not fit for motherhood is a huge barrier for women accessing services. Next slide, please. System pressures was a huge discussion. So starting with, again, the definitions of the different criteria for perinatal mental health, a lot of women are struggling, but the symptoms or their experiences are not meeting the set criteria for perinatal mental health. And so a lot of women talked about being turned away from services because there was nothing available for them. So women are falling through the gaps because of those high thresholds. And also, even for women who are accessing services, feel that the process of assessing their mental health status feels more like a tick box assessment, and there's no real dialogue, no real conversation about what they might be experiencing and what the challenges are. And all of this and it is partly due to things like time restrictions. So there's lots of system pressures on healthcare professionals, very limited time to engage with women, which then limits their ability to build a rapport with these women and to really engage with them as they would like to be engaged with. And also no continuity of care. For example, a lot of women talking about seeing several different midwives throughout their pregnancy and not really building any relationships. Whereas a good relationship between a mom and a midwife was a big facilitator for the women to be able to understand services available to them and to be able to access these services. So this continuity of care wasn't there, was lacking, and partly due to staffing shortages. And so there's just a lot of system pressures that are affecting the ability to support women appropriately. Working in silos, so there's lots of different services that women experiencing disadvantage are in contact with. For example, women might be in contact with services for maybe a homelessness issue or financial challenges, or even women who might be experiencing addiction issues. So these different services are providing these different services are there supporting women in different ways, but then mental health support is not integrated into these services. And so the care is fragmented, and women are not able to access the care, the support that they actually need. And some women also, for example, a woman might be experiencing an addiction issue and might be referred to a service where she can be supported for a mental health issue, but then she's expected to have the addiction issue resolved first. And so there's women just going between services and no integration of this care, which further marginalizes some of these women. Next slide, please. In terms of the services, a lot of women felt ignored or dismissed and judged or not taken seriously. So this was in situations where women actually had some opportunity to talk about the challenges that they were experiencing in terms of perinatal mental health distress. So phrases like, it's normal, oh, it's just a baby blues, it's not that serious, it's just a phase, it's all in your head. These were some of the phrases that women talked about, which to them meant that they weren't taken seriously. Some of the women were even asked to deal with it. And so a lot of this contributed to women just not trusting that the system really was there to support them. And professionals that we spoke to acknowledged as well that there might be times when they really fall short in being more compassionate to the women. And although they do have that passion to support the women, they might tend to overlook the emotional side of things, whereas that's actually what the women need. So this is another huge barrier to women accessing existing services. Next slide, please. Cultural insensitivity was another issue, again, with the general population being multicultural. Participants talked a lot about a general understanding that everyone understands the healthcare system, whereas that really isn't the case. We've got people coming in from other countries with different healthcare systems, and even information that's being provided to people about services are not accessible because the information is always in English. There's a lack of interpreters, and so the cultural appropriateness of the healthcare services and settings is in question, and there's a need for training on culturally competent perinatal mental health support. So some of the professionals that we spoke to talked about, for example, some professionals who were born in the UK and had lived in the UK all their lives, acknowledged that even to them, the healthcare system could be challenging, it could be complex and difficult to understand. And so imagining the complexities for women who are new to the country and just expecting to understand how things work. So there's really a huge need to signpost women and to support them to understand what services are available and how they can access these services. Now, GPs were usually a first point of contact for a lot of women. But then the challenge with this is that women found that when they would talk to their GPs about experiencing mental health issues in the perinatal period, GPs would tend to prescribe medications like sleeping pills or antidepressants, rather than maybe signposting them to a service where they could talk more about the challenges that they were experiencing and getting more support. So there were questions about whether GPs actually are well placed to be able to support women or to handle issues with perinatal issues relating to perinatal mental health. And this question came up relating to the time that GPs usually have to interact with patients and the workload that they have, and even looking at GP training, what level of interest is there relating to perinatal mental health or the emotional side of things. So again, it's just understanding who's better placed to support women more appropriately. And also a lot of women who had specific experiences like grieving moms or moms who had children with disabilities felt that the services were not meeting their needs. They felt that the conversation just tended to gloss over things, and there was no real space, no real opportunity to really understand them and to really support them the way they wanted to be supported. Like some women with kids who had disabilities felt that the conversations were more focused on raising the child with the disability, but nothing more on how the parents were feeling, how the mom was feeling, and how she could cope with the situation. Next slide, please. Yeah, so that's a very rushed summary of the findings. There was a lot more that came out of this study, which I can't talk about all in this session. This is a summary of recommendations that came up from the professionals that we spoke to on how to improve and facilitate these women's access to these services. So the first one was developing initiatives focusing on introducing women to perinatal mental health services and helping them to understand what options are available to them. And part of this involves talking to the women during pregnancy and trying to help them to understand even generally what perinatal mental health issues are and can be, and what they can expect from it, who they can speak to, providing contacts, things like that. And also just the emphasis on services being more flexible and adaptable to the needs of individual women. For example, providing services in more informal and familiar settings to reduce stigma associated with seeking mental health support. So this could address maybe the fear of going to like a hospitalized kind of setting. And so you just bring in perinatal mental health support to women in the community, and also encouraging the framing of mental health messages in a more positive light, emphasizing on the benefits of seeking care for women rather than always talking about the negative aspects of mental health. So doing this could empower women to want to do this more. Some service providers talked about creative ways that they engage women in talking about mental health. So there are creative therapies where women can connect with other women and express themselves and get support in and be in a supportive environment with other women with shared experiences. then it's important to acknowledge and address the social determinants of health and how that may impact women's mental health. So again, going back to that integration of mental health support in different other services that exist in supporting women in different aspects of their health. Engaging in activities that build trust with women and their communities, for example, using collaborative and culturally sensitive approaches, and also using trusted communities, right? There are organizations that have been working with these different groups of women and these different communities over the years and have built trust with them, understand the women's needs. So it could be very useful to work with these organizations to be able to get access to these services and to be able to understand the needs of the different communities. And lastly, ensuring cultural sensitivity during the design and delivery of services by tailoring the services to the cultural needs of women from diverse backgrounds. So again, moving away from the one-size-fits-all kind of approach and understanding that different women have different needs, different communities, different populations, and just seeing how to address these different needs in the design of services. And I think that was my last slide. Thanks. Yeah, so thank you very much for listening. I saw some questions coming up. I'm sure that we can address them at the end. Thank you.
Thank you very much, Lem. So we've heard from our two projects. I would like to, we're just a little bit behind schedule, but I'd like to suggest that we go ahead with our 5 minutes comfort break, and then we'll come back and have the Q&A session. We've still got plenty of time for your questions and comments, so please don't worry about that. So we will come back at 12 minutes past 11, if you could all be back by then, but please do stand up, move about, and do maybe grab yourself a cup of tea if you've got time. We'll see you in 5 minutes. Okay, so welcome back, everyone. I hope you managed to have a quick break at least. We'll now move to the Q&A session. As I said, we have Lem, obviously, and Ange joining us for this, but I'm also very pleased to say that we have got some other panel members. So I would really like to invite Laura Seabaum and Guy Pilkington to introduce themselves, and not only who you are, who you work for, etc., but perhaps you could give us a little bit of insight as to why in particular you wanted to join this huddle around the topic of perinatal mental health. So Laura, I'll move to you first, if that's okay.
Hi, thanks Judith, it's great to be here. So I'm Laura Seabaum, I'm Chief Executive of the Maternal Mental Health Alliance. We're a national UK-based membership organisation, basically committed with our members sort of span from grassroots community organisations right to the Royal Colleges, all kind of everyone working that perinatal mental health landscape, committed to improving. And for us at the Alliance, it's about making sure we're reaching all women. And so I think coming here today and listening to the role of the voluntary community sector is absolutely key about how we make sure that we're I guess really trying to tackle those disparities of outcomes for some groups of women. And it's brilliant to see you again, Lem. I met you, I think, at the start of your research, and yeah, just found it's just so interesting, so much we have to do. So I'm very passionate about this, obviously, in my role. And just quickly, previously, I set up and led women's services for North East charity, Changing Lives. So another very reason I'm delighted to be here today, because obviously I'm sitting here in Newcastle, and the North East is always where I like to promote best practice. So thanks.
Thank you very much, Laura. So it's where your heart is, yes. And Guy, can I ask you to similarly, if you could just introduce yourself and then why in particular you wanted to join this huddle?
Yeah, thank you, Judith. So I have a number of hats that have led to me sitting on the panel. The most obvious is I have taken on the role of chairing Ways to Wellness from Chris Drinkwater, who I believe is on the call. And Chris has much more responsibility for the opportunity that we had to work with Ange and others to deliver the prototyping project for maternal mental health link worker models. I also am a GP by profession, and I work in a very deprived area of Newcastle, in the West End of Newcastle in Credits Park. So the inequalities agenda is very important to me, and I am one of the chairs of the Regional ICB Prevention Board, which is attempting to support moves upstream, as I think people mentioned in the presentations earlier, to support people at earlier opportunities. And one of the agendas within that is the Prevention and Public Health in Maternity program, which people like Becca Scott have been working on for many years, many of you will know, and I think is delivering some fantastic results. In terms of being on this particular panel, I have spent a long time and continue in this role at Ways to Wellness, trying to help statutory services understand the enormous added value of working with a different workforce that is socially rooted, community orientated and person-centered. And I think in that respect, both presentations have really strongly endorsed the added value there. And I want to work with you to promote that whenever feasible. But I do understand, as a former health commissioner myself, just how difficult it is in the current climate to make those changes. And so this whole meeting should not be seen as a challenge to professionals, but as an opportunity. And how do we get the voluntary and community sector augmenting the fantastic stuff that professionals are doing on a daily basis?
Thank you very much, Guy. Thanks. Laura and Guy, for your introductions. So I said earlier that I would give you an opportunity to ask Ange and Lem any specific questions you have about their projects, and then we'll open it up to maybe a more broader discussion. I've got somebody in the background. I don't know if you could mute yourselves if you're not speaking, just so we don't have any interference. So who would like, we've had some comments in the chat. I think some of the practical issues, both Chris Drinkwater and myself have tried to answer, but please feel free to ask anything of the project leads. And then, as I say, maybe we could open it up into a wider discussion. Would anybody like to start us off? Yes, Margaret, thank you. We have Margaret. If I could ask everyone if you wouldn't mind just introducing yourselves and what organisation you've come from, etc. That would be really helpful for our panel members as well. So we'll start with Margaret. Thank you.
Hi, I'm a health visitor of, 30 years now in Newcastle. Worked in various areas such as education at the university. I've taught there for a while, but I'm back in practice as a return. Guy, I'm going to direct this one to you. Do you think we have data collection? Because I'm not quite sure if what health visitors are offering is coming through in a lot of people's data. Do you think it's a problem with how we're recording things in Newcastle? Because I know we're doing at least 5 or 6 questions to mothers about their mental health. And I know we cover things like stigma, cultural issues, and also I know that we cover things like your child isn't going to be taken away. So it was quite shocking for me to hear that. So what are we doing wrong? Why is this not coming through for us?
You broke up just at the early part there, but I get the drift of the question, Margaret, which is, if health visitors, and I'm sure midwives would absolutely aspire to do the same, to be non-stigmatizing and supportive of people to reduce the fear, if you like. If you're routinely doing that, why isn't it always landing with the people that you're talking to in ways that resonate with them? And what do we collectively, as a health service, what are we getting wrong? As Lem's qualitative research would suggest, sometimes we're not having the impacts that we want. I think the answer to that question is very complicated. I think a lot of it does have to do with the circumstances in which we're all working these days. I think there is relatively little time for reflection. And I think what Lem's quotes, for example, gave us was this: we can have impacts with very short phrases, such as, oh, well, it's very normal for people to feel the blues. We may be giving that as a reassuring, supportive comment, but it may be received very, very differently by the person as a dismissive comment. And sometimes pressure of time is impacting, I suspect, on how our supportive conversations are being perceived. I think that pressure of time takes us away from the ability to allow the person to set the agenda for themselves. We often go into a consultation with a set number of tasks that we know we have to cover, and they can take precedence, I think, sometimes for the individual in a way that will make them leave the consultation feeling like the conversation was less for them and more for the professional. Now, these are terrible stereotypes, and I think we all strive all the time not to do that. But I think we do have to listen when you hear these quotes, when you get this quality. We do have to be willing to at least acknowledge that our perception of how the conversation went may differ from the person on the other side of the conversation. I don't know if that helps at all, Margaret. It probably doesn't.
I think what I'm driving at, Lem, I'd like to ask Lem, I don't know, how many health visitors did you talk to? How many health visiting services did you engage with for your research? Because we have such a focus on perinatal mental health, and we ask these questions, we use evidence-based tools to screen. I'm just wondering, were you able to speak to health visitors in your research? And
yes, we did. We had at least 7 who were still health visitors, and also others who had moved on to other roles but had previous experiences of being health visitors. But just to answer, so there's so much that came up around these conversations. So it wasn't that the conversations don't happen at all. For some women, they did happen, but it was a question of how the conversations happened. So for example, some women talked about feeling like a number on the list, where there was a sense that this person is busy and has other things they want to get to. So being asked a question like, how's your mental health, doesn't really give you the space to talk about how you're feeling. So there were things around how the questions were worded, and also the interactions with the health visitor or the professional that they were speaking to. A lot of women had problems building a relationship with a person. So before they actually get to the point where they can express themselves, they needed to have a trust type relationship with the person. But that wouldn't happen if, say, your midwife or your health visitor keeps being a different person every time, or even if say you just don't get along with the person. So these were some of the issues that came up, and even the conversations in themselves were not really, for the women, didn't feel like there was that real genuine interest in understanding what they were going through, because first of all, they've already been made to understand that what they might be experiencing isn't new. Other women have experienced them, it's normal. So it's quite a number of things.
And I think we,
I can honestly reassure you that we would never say that it is normal. But you know, I think there's a lot social media as well.
Yeah, I think there's a lot in here. You know, clearly what Len was just alluding to there is that it's not that the conversations are happening, but maybe it's the way they're landing or the way that they're perceived conversation to be. So there's, you know, there's obviously some work to be done there as well. But absolutely, and we know obviously there's a very busy health professionals who are trying to get through a lot in very short time with the women. So it's not always going to be perceived in the same way as it's meant. So just some questions there. Some people have got their hands up now, which is great. So we'll move on to Lucy. You were next, Lucy. I don't know if you've come off camera. Thanks, Lucy. What's your question?
My name's Lucy Owens. I work for Catalyst. We are the infrastructure charity for Stockton-on-Tees. And I just wanted to ask Ange in the presentation that she was giving about the link workers. I just wondered whether you engage with volunteers on that project.
Yes and no. So each of the 4 prototypes is different. We do have one of our prototypes where we'd had a mum who had access to link work support, who, as she moved through her recovery, came back to us and said she'd identified a real gap, a need in her area around peer support. We found in our rural Northumberland project that mums would quite often travel out of area, for example, to access mother and baby groups even, but there was a real lack of peer support. So one of the really nice things about this project and the flexibility, I guess, that we had in the funding is that we had the flex to be able to look at setting up some new peer support groups. So we've actually supported that mum to engage with Pandas Foundation, which is a national organisation working around perinatal mental health, to develop new peer support groups. And we'd supported that mum to with some funding to find a room, and also with some funding to cover things like DBS, to be able to get a new peer support group off the ground. I noted kind of comment in the chat specifically about, I guess, that challenge around, is this the type of support that, you know, other sectors feel could and should be offered by volunteers? And I hope what's come through in the presentation is the specialist nature of these link work roles, but I think there's a real there is a real opportunity for that wraparound support and to be engaging volunteers, and I think that's something that we would welcome moving forward. But I think we know there are really brilliant volunteer-led projects out there that are working in this space, but I think the level of complexity that we found, particularly working around health inequalities, has meant that we really have needed this to be that very specialist link work role and focused in that specialist way.
Yeah, and I think, as I said in my comment, I am absolutely not saying that I think that is a volunteer role. We just, I'm sure lots of people experience this, especially those who are working in the VCSE sector. We get a lot of questions saying, could this be volunteers? Could this be volunteer led? And while that's often really appropriate, and we've got some wonderful volunteers, us at Catalyst, and I know my colleagues locally and nationally, are finding it increasingly difficult to find volunteers, because that seems to be a lot of people's go-to answer where there's cuts elsewhere. Well, let's get volunteers in. And again, sometimes that is great, but there's also that incorrect assumption in some quarters that that means the whole thing is free of charge. Whereas if you've got the funding to set up projects and have the volunteer coordinator and management support there, then yes, you absolutely can bring volunteers in to help. But we're just working quite hard in our area to make sure that message is getting through, that yes, you can look at setting up a volunteer project and you can really utilise volunteers, but you need that element of paid support for continuity and just to make sure those volunteers are supported. And we're just about to start a new project, recruiting volunteers to support social prescribers, to help people that they're working with to access community-based support. And we're just trying to puzzle through what that could look like, because we've all experienced designing these things on paper and then it's not really what people need to help them access the community-based support. And unfortunately, it often comes down to things like travel, and we don't really want volunteers giving people a lift and things like that. So yeah, I was just interested to know really with where
Laura,
we are with
Laura, could I bring you in there on that particular
Yeah.
part? I could see you nodding your head at
Yeah, I
quite a few
think
points.
this is really interesting, and I think it speaks to what Guy said in the introduction around, there's something around the power imbalance, I think, around the voluntary community sector. And I totally agree, Lucy. I mean, volunteers are absolutely vital and play a crucial role, but also it's, you know, we're hearing on a national level that a lot of our member perinatal mental health peer support services are being commissioned, but only for the project, no core costs. You know, that the kind of the voluntary community sector is seen as a very cheap option, but actually there's a lack of parity and understanding of the absolute skill. And for me, it's around our statutory health services, fantastic. But actually, if we're really going to tackle health inequalities, we really need to work out how we engage together better with really grassroots community-led voluntary community organisations of all different shapes and sizes. And I think it's hard for large sort of health structures to know how to do that, because rightly so, the voluntary community sector are diverse, we're messy, we're different, we're organic, we evolve, and that's the beauty of it. But I think it's very difficult for health. I think Ways to Wellness and sort of this project is doing it in this area so much better than many. But I even notice in the presentations, this is absolutely not critical, but some of the language we use around, you know, we're sort of being grateful that we're trusted to work with complexity. Well, actually, the voluntary community sector have always been absolutely leading the way, or sort of being described as we're filling the gaps. We're not filling the gaps. We're playing a crucial role to engage people with the most challenging lives to get them into those sort of health services when that's needed. And just lastly to say, you know, when we look at things like the horrendous disparities of outcomes for women of colour in the sort of maternity settings, actually it's the voluntary community sector organisations who've led that campaign. It wasn't politicians, it wasn't statutory services, it was real campaigning from you know, Black-led women's organisations. So I just think we need to be very strong around our language, around making sure we give that equal power, sort of parity of esteem, I guess, to the voluntary community sector.
Thanks, and thanks, Lucy, for your question. So we've got Louise now, Louise Dorr.
Hello, I'm Louise Dorr. I work for the National Academy for Social Prescribing. So really interested to hear more about the service. I have been and looked on the website because you're so brilliant at sharing all that learning already, but it's really great to hear the updates on it. So I have kind of selfishly asked 2 sets of questions in the chat, and they both in a way follow on from the discussion we've just been having. I guess I'll pick my second question first, and maybe we could always go back to the other one if nobody's asked it at the end. So my question was about, you've put these link worker roles in, and they are probably then increasing the referrals to the range of community-based activities and support that these women can access and are entitled to and should be accessing. But has there been any pushback there saying you're stretching our capacity? Have you responded to that by extending the investment into the wider VCSE sector and range of activities? How have you approached that?
Thanks, Louise. That's a really good question. We haven't had, I don't think we could describe what we've had as any pushback. I think where we have identified, and this is probably really unsurprising, is just how overstretched financial support services are at the moment. So most of the women coming through the project have identified challenges around cost of living crisis, around budgeting. We know our food banks, baby banks and financial support services are really overstretched. I think we'd had a conversation last week about how some of that is being responded to. So we have our Middlesbrough based link worker highlighted that she'd had some challenges with getting support around citizens' advice, but had identified that actually based within GP practices in Middlesbrough, there was an increasing presence of financial support, so was able to make that connection for women there. I think what we've also found is that because we've been working with smaller numbers, because this has been prototyping, I'd like to think that we haven't overwhelmed any one part of the system, but we did identify quite early on, and I think, as I said earlier, we wanted to keep some of that funding for peer support. So where we've identified gaps, we've used that funding to be able to fill those gaps. We've also been able to be in a really good position because of how we've evaluated this work to be able to support some of those smaller VCSE organisations in making applications for funding to do more support around perinatal mental health. And I think, again, because of the smaller numbers that we've worked with and probably just the diversity of need that we've seen across the women, we probably haven't overwhelmed any one part of the system, but particularly those that, the issue of financial support feels really important. And that probably has been where at least most women will have had a referral go through for support. If not at the initial stages, sometimes multiple stages, because I think we found that people's financial situations have really changed as we've worked with women. Their partners have maybe lost jobs, lots of issues around kind of employment and insecurity. So I guess we have bounced people into those financial support services quite frequently.
Louise, what we'll do is we've got another question this time from Chris, but we could maybe come back around to your first question if we've got a bit of time left, if it's still relevant, hasn't been answered.
Fantastic, or somebody else might ask it anyway.
All right. I'll hand over to Chris Drinkwater now.
Hi, good morning, everybody. I just wanted to come back to this important question of the lens with which we look at all of this. If we look at it through a mental illness lens, we inevitably end up asking questions about mental illness, which, as LEMS research shows, it isn't necessarily useful. And for me, the primary causes are poverty, low self-esteem, and sort of social complexity, which all give rise to mental ill health, basically. And if we were to look at this through a poverty proofing lens rather than a mental illness lens, we might end up asking a very different set of questions and having a very different discussion. And I think that's been some of the learning. I mean, if you've got a new baby and you can't afford some of the essentials, just buying nappies, disposable nappies, for instance, then you're not going to feel very good about yourself. And so there's a sort of a serious question here about what's the lens through which we're looking at all of this. And I suppose sort of the question is really to Guy and Laura, and in terms of how do we change the way we look at all of these issues?
Okay, so Laura, would you like to come in? That's Chris's your challenge.
Yeah, I mean, great question. I think you're really right in many ways. I do think there are some perinatal mental health problems which are not necessarily related to sort of social and economic complexities. And I think it's really vital that we have, you know, if we think about Margaret, you know, health visitors, you know, 97% of new parents will see a health visitor. And I think the crucial role of sort of like working that out around because those cases are incredibly high risk and dangerous. But I absolutely agree. When we look at all the disparities of outcomes, you know, multiple adversities and race, ethnicity and deprivation just come at the top. And you know, I remember meeting up with you, Ange, really quite near the beginning of this, and saying that some of the mums your link workers were supporting were already watering down infant formula. And I know in some places the highest item that's shoplifted at the moment is Calpol, and you're like, this is devastating, really. It's such an indictment. And I'm going to speak really sort of honestly, really, I guess when I came into this role as Maternal Mental Health Alliance from the sort of North East Changing Lives charity sector, I was really shocked at how little was being discussed around socioeconomic factors, and even sometimes actually being told that's a social issue, that's not what we do, that's not, you know, this isn't relevant. And I still notice that in policy sort of professional meetings that I go to sort of routinely, when we start to talk about sort of multiple adversities, and particularly things like, you know, poverty and addiction, it's very uncomfortable. People find it really, really uncomfortable. And I think it's much easier to locate the issue with the individual rather than look at our wider structural factors. And I think that's a real, I think it's not unacceptable, really. There's something I was going to say with that you know, listening work, sort of deep listening work with women who faced domestic abuse, poverty, addiction, sort of all those sort of interrelated homelessness issues, who also really, really experienced poor maternal mental health problems. And I mean, the findings aren't out yet, but in just initial conversations that I've picked up, the headlines are that people are much more comfortable locating the issue with them as an individual, and particularly addiction, and it soon becomes into a kind of punitive feeling of punitive sort of punishment rather than support. And I think for many, that's a more comfortable place to locate things rather than our shocking inequalities in this country at the moment. So I think you're absolutely right, and we need to keep banging that drum, really.
Can I bring you in, Chris, challenge both you and Laura to come around this question? So I'm conscious we've got a couple more questions, yes, but I'd like to take it to you, Guy, for this response.
Yeah, I desperately wanted to come in because, you know, nobody who knows me will be surprised I completely agree with Chris. I've spent my career agreeing with Chris. But in this respect, I think it is a really important question. I think you know, GPs, we're generalists, health visitors, Margaret is a generalist, and we absolutely will believe that we sign up to the biopsychosocial model of health. In other words, we are willing to engage in physical health, mental health, and the social situation in which people are struggling. And yet, one of the really interesting bits of feedback we got in one of the early prototype review meetings that I was at, a mother described how it was only when she finally met the link worker that she was able to feel that her problems were being addressed and supported in the way that she could engage with. And I think she had a label of emotional unstable personality or something. And I remember saying, this is really specialist work that this link worker is doing. This link worker has broken through to an individual who, however many professionals they met, still felt judged, stigmatized, dismissed, or something. I have no idea. And it was only on meeting somebody that she felt could understand her, whether it's because she came from the same community or had similar lived experience. So we should not underestimate the special skills that non-professionals can bring to augment the work of professionals. It's really important that we recognise the value of that. And I think Chris's question, and why don't we use that lens of the social much more, I think is because we don't understand the relative importance of the harm. I think if we spent enough time thinking about being pregnant, having children, bringing children up, and thought about where are people being harmed from, the importance of those social factors of domestic abuse, of relationships at home, of poverty, of the impacts that all of that has, we would see this as a much, much more significant thing for us to be working on with people. But because we are medically trained, because we are deeply rooted in medical models as professionals, we tend, I think, to underestimate that. And I think having co-workers to support us being able to give a holistic offer, I think is really critical, because however much we would like to think, it is harder for professionals to break through in that space. I think we are aided and abetted by having this new workforce work with us.
Excellent, thank you. We've got 2 more questions and I'm really keen to get through these in the time that we've got left. So can I go to Moira?
Hi, thanks, Judith. Not a question so much, just as a comment on sort of what Laura was saying and Chris. I work in the public health team in Gateshead Council, and I've been fortunate to be part of the Family Hub Start for Life agenda. I think, without getting political, the government's really missed an opportunity because it's so narrow and focused in terms of what can be done with the funding. And it's really stymied some of the work we could do, listening to what we've said about those issues that families are facing, and because of the minimum requirements and what we're required to do. Whereas if they'd sort of looked at it a bit more holistically, there is so much more that we could have done to help families in our regions, I think. Anyway.
You're getting lots of nods, Moira, certainly from the people that I can see on screen. Thank you for your comments. Julie?
Hi Judith, I'm a health visitor. I work in the Darlington area actually of the patch, which I don't think is covered by Angie's project. I was really excited to see at the end of your slides that you were talking about, projection and future and things, it being rolled out possibly in other areas. I certainly can see a role for a link worker in that way, specifically around emotional wellbeing. I work with the iHealth Visitor organisation, and I deliver a lot of their training for them, and I've been involved with them for about 8 years now. The main thing I wanted to ask you about was the area of increased parents with learning difficulties. I certainly, in my years of health visiting, have experienced that much more. And in our particular patch, it's homelessness. There is, I have 2 young mums currently who both been made homeless by their own families, and there just isn't any sort of network to support them. They're living in hotels. And I'm wondering if that's right across the patch, Ange. Is that across the northeast, or is it just local to our area?
Yeah, I think we have supported a number of women who have found themselves in similar situation and similar circumstances, often younger mothers. We did do a little bit of a deep dive specifically to understand the support needs of the younger women that we've supported, and homelessness and challenges around housing came up really frequently in that conversation. I think you raise an equally really important point around learning disabilities, and I think we didn't have time to talk about this today, but one thing we've talked about as a link worker learning community is we feel we've identified a real advocacy gap, particularly around support for women with learning disabilities and around women at risk of child removal. And obviously at that kind of point in time where housing situation becomes really, really difficult is often a time when either early help support is really needed, and women feel very frightened about what's going to happen for them and for their baby. I think a number of women that we've supported have experienced those challenges around housing, particularly during pregnancy, and have really needed a lot of support. Quite often we might get a referral quite kind of late on in pregnancy, and I think one of the things we've said is that from that preventative aspect, if we can start working with women as early as possible, we can't always solve all of those problems around housing, but we can start to look at those things much more early. I think that North East and North Cumbria, we've seen some really nice work recently around the Diamond standards, around support for women with learning disabilities within maternity. If people haven't seen those, I'll share them with information that will go out after this event. But I think, yeah, just to tie that up, I think we have identified an advocacy gap, and I think we've thought quite a lot about whether the link work role is fulfilling some of that advocacy need and whether we should be fulfilling some of that advocacy need too.
Thank you.
Thank you, Julie. So
what about rollout? Sorry, are there plans for a bigger rollout, do you think, or not? Is that I'm new to this, so is it a possibility?
We'd love to, Julie. I think, as I said earlier, I think that from an evaluation perspective, the services evaluate really, really strongly. We've seen a need both from the women and a response from the system that this is something that's meeting a need from a resource perspective as well. I think that we just, it's such a challenging financial environment at the moment, as Guy identified, but we're really keen to explore all options around that. And I guess, initially what we'd thought about when we set this up was, let's pilot it, and we'd love to see this rolled out across North East and North Cumbria. I think we might end up with a bit of a patchwork quilt where we have pockets of funding from different sources, and I think we're really keen to explore those things too. But yeah, from my perspective, we'd be really keen to explore that further and really keen to have conversations.
Maybe I was going to say that might be the next step in terms of taking a conversation beyond this meeting today between the two of you. Louise, I just want to give you the opportunity to maybe ask your first question that you didn't ask, if it can be answered fairly quickly. Sorry about that, but we've maybe got time for one more.
Very kind, thank you. So my question was, taking off my sort of social prescribing system hat and putting on my social prescribing workforce hat, which is we do see in some areas of the country problems with retaining link workers. So people will get skilled up and then go and do a non-clinical role, perhaps working in the NHS if they've been VCSE employed. So I was just wondering if you've had any issues with that, if you have taken any steps to recognise that these are specialist skilled roles, and yeah, how you've kind of thought about that parity of pay. Goes back to the parity of esteem between the sectors, doesn't it?
Thanks, Louise. And that is perhaps a conversation that we can take forward offline as well, because I think there's much more that I'd like to be able to say around the specialism within the role. We've had a couple of link workers move on actually, and we've been able to recruit fairly quickly back into those posts, and I think that's probably testament to the social prescribing link worker community, really, that we've identified people either working in existing in the services that we've worked alongside, or who have had posts that have maybe been coming to an end in other services. It just is an ongoing real challenge around this kind of work. We were only able to offer the link work as a 12-month post as we were getting the project off the ground. We've been able to extend the services a couple of times now, but we are getting again to a bit of a crunch point with the project, and it's really difficult to retain people during that time. We've got an excellent, really strongly skilled workforce within this team, and I think that's testament to the link work team and how brilliant they are. It's also testament to the learning and the training that we've been able to put in place along the way, and I think that was another thing that I guess the benefit of having an organisation like Ways to Wellness in the centre of that has been that we have been able to commission training for the link workers centrally and look at ad hoc training and put things in place in that respect too. And then just to take the second part of your question around the specialism, I think these roles are specialist both in the nature of the work, but also specialist in that we set this up as a learning project. So we recruit for link workers, but I'm really glad to say that we've also recruited really curious people who are prepared to come on a bit of a learning journey with us and look at trends and themes in their caseload. And I think the link worker learning community has both helped with that and possibly has helped with some of that retention too, because these are lone roles. There's only one social prescribing link worker in each organisation, with the exception of Northumberland, where we have the 2 part-time roles. So being able to bring them together for that peer-to-peer support has felt really important.
So I'm really sorry. I think we are going to have to draw this part to a close. Charlotte, I realised that you had a question to ask. I wonder if you wouldn't mind maybe contacting the speaker or the panel member that you wanted to direct that question. I know we could all spend the rest of the day talking about this, but unfortunately we need to move on. I just quickly want to wrap up and before I hand back to Amelia. I think there's a few things that have really kind of chimed with me, just very quickly to say, clearly this is a really important area. We've all recognised that. We wouldn't be here and we wouldn't be giving over a huddle to this topic if it wasn't important. I think it's increasingly important, and I've looked at some stats that we do have recently. We don't have a lot of data on this, but it is definitely increasing. I think Anne showed very well that the VCSE based support can be a really effective approach, relying on a certified reach and a certified reach approach working, but very much based around that trust element. I think Lem very eloquently discussed a number of barriers to accessing services. I would like to just say one thing, that although this has very much been around maternal perinatal mental health today, we absolutely acknowledge that we need to be doing work around with dads. Ange has already alluded to some work that she's doing, and Ange is very aware of work that we're doing that she mentions as well around paternal mental health. So it may be we might come around that in another huddle in the future as well. So I would just like to end by thanking our speakers, thanking our panel members. I was going to ask the panel members for a sort of one sentence and what they would take back and what they would do in their roles, but unfortunately I think we don't have time for that. So I'll hand back over now to Amelia for some other news around the network, and then I'll do my final thanks. Is that okay, Amelia?
That is fine, absolutely fine, and I'll do it quickly because I'd really like to hear the one-line summary, so everyone's got a chance to prepare. So I was just going to talk a little. So I'm a network development manager with the Child Health and Wellbeing Network, and I was just going to share a couple of little bits of our work. We've got our Healthier Together website and app. Hopefully everyone will have heard of this on the call, and if you haven't, please do get in touch and we can share more information with you. It's a locally developed NHS resource, and there is tons and tons of resources on it, and we keep building it, and it more and more gets added on. There's also the Recite Me function on it as well, and there's a toolkit to help promote it with newsletters and different organisations, and our colleague Laura's email is there if you'd like any more information. Our ask is that people download the app and access the website.
So yeah, briefly.
Oh, someone just come off mute. So communicating and engaging with the network. We have Child Health Tuesday, which comes out to our almost 200 network members. So if there's any pieces of work or events or opportunities that you'd like us to share, please do get in touch with our main inbox. We've got our X account. And we've got a number of different groups, including our system engagement group. So if anyone would like more information on how to join that group, you're very, very welcome. Again, please do get in touch. And final little bit is, if you're not a member of the network, please do sign up. There's a QR code, and I'll pop a link in the chat as well so that people can access the Google form. And yeah, that gives us a few minutes for everyone's final bit. Okay.
All right, so I would like to specifically ask Guy and Laura for their reflections, but much more from what you've heard today. So what will you take back to your organisations in terms of next steps?
You go, Laura.
Okay. Wow, I've learned such a lot. It's been absolutely fantastic. I think my sort of real take home, I was really struck by the learning and evolving with the learning, and I think Lem's research is so important. Some of it's hard listening, but you know, it's so vital that we listen to that and learn from it. And then I was really struck with the principles of how Ways to Wellness, how the prototypes, the sort of principles behind the setting up, having learning at the heart of this. And so it's the being able to evolve, meet emerging needs as they come. And so it really made me think, this is quite unique. There aren't many places where this is going on in this way, and it's something to be really proud of. For me and the Maternal Mental Health Alliance, I'd really like to amplify it and sort of showcase it somehow in some way. So I'll be in touch about that, because I think the vision of investing in these prototypes can't be underestimated. I love that they're all different. They're all, and there's so much learning that on a national level. So I think that's what I will take back, and really hope I can do justice for the fantastic work. It just shows that how important it is, this beautiful partnership between voluntary community sector and statutory, health services, when it works, can make, it is the way forward. It's the solution to tackling all those the sort of persistent, stubborn health inequalities that we see. So, and I'm really pleased to come to an event, my final thing, where there's a real spotlight on the poverty and inequality that I don't always see in my role. So yeah, I'm delighted that that's really been at the sort of forefront and centre stage of the discussions. So thank you so much for having me.
Thank you, Laura. And then Guy, if we can turn to you, and so how will this event and what you've heard today, how will that inform your discussions at the ICB?
The North East and North Cumbria ICB, it's a geography that we like to think we are at the forefront of developing different ways to respond to what we call, or is widely described as, the health gap. We have really generally pretty good health services across the board in the North East and North Cumbria, and yet we have really, really poor health outcomes in perinatal mental health. It will be no different. We have, people who are striving hard on a daily basis to support people as well as they can. And yet the gap between what we aspire to and what people experience and the results that they live with every day is worsening because of cost of living, poverty, child poverty in the Northeast, and so on, all of which are getting worse. So this is not becoming less important. This is becoming more important. We strive to be at the forefront in the Northeast in developing new ways of creating alliances that will work better together to address these problems, but it's a real struggle. There's no question this is in the difficult to do box, and I would love to see something like this rolled out to every local authority area in the North East and North Cumbria, but I know that that's going to be it is a very difficult ask, and we have to support those people who hold the influence on those budgets to see that this is not poor investment. This is investment for the future that has enormous impacts for communities, for families, for individual men, women, and the children that they have.
Thank you, Guy. And I think it really is something we need to hold on to, that we know about Best Start in Life. This is about that. If we get it right at this, it will reap benefits throughout the lifespan. So as I said, we could keep talking for ages, but we are at 12 and I know people will have other things to go to. So it just leaves me to thank our speakers, Ange and Len, for their excellent presentations, and also to Guy and Laura for being part of our panel. I'd really like to thank Amelia and Jen, who are doing it all in the background. I just have to be here. They've done it all of the organisation, and I just really want to thank all of you who've attended today. And I know we're all very busy, and taking time out like this feels sometimes like a bit of a privilege, but I think it's really important to do so and to listen to our colleagues. So thank you all very much, and I hope you will continue to engage with the network. And if you're not a member, please do sign up through the various methods that Amelia told us about, and all of the slides will be available after. So I hope you have a great rest of your day. Thanks very much.
Thank you.